Welcome, everyone. I'm Christine Bevick, task lead for Recover at the Administrative Coordinating Center, and I'll be your moderator for today's webinar. I'd like to welcome everybody to today's Recover Research and Review, or R3 webinar. For those of you who might be joining us for the first time, the overarching goal of this webinar series is really to catalyze the formation of a scientific stakeholder community within and beyond the Recover Consortium. And that includes fostering a shared understanding of the state of science and providing an educational resource for both Recover investigators and the broader scientific community of clinicians, patients, and public stakeholders. I'm going to start by thanking everyone who submitted questions in advance. During today's webinar, as Catherine mentioned, please use the Q&A feature in your Zoom window located at the bottom of your toolbar there to submit your questions. And after the presentations, our presenters will be answering as many questions as time allows. And some of them might be responding to those questions also in real time within the Q&A. But please note, we unfortunately will not be answering any questions about clinical care. So the questions will appear in an FAQ for this webinar, and that's going to be posted along with the recording on recovercovid.org. So give us a couple days and then you'll see it there. Today's webinar is part of our ongoing series, Recover in Action. Today's session will focus on the characterization of PASC among children and adolescents. Our presenters will be addressing the question, what is the clinical spectrum of PASC, including subphenotypes, among children and adolescents? And they'll be sharing those results using EHR electronic health records, real-world data, and data science. If you haven't already, please remember to sign up on our website to receive future announcements and updates on the series. Our standard disclaimer, as Recover continues to grow, we want to remind our audience that the information presented in this seminar is intended to stimulate collaborative dialogue amongst both the Recover scientific community as well as study participants and other interested parties. The information may be recently published or about to publish, and as such is potentially subject to change. In addition, none of this information should be interpreted as medical advice. So please join me in welcoming two of our Recover investigators joining us. It's my pleasure to introduce Drs. Suchitra Rao and Dr. Vitaly Lorman, and they're joined by our discussant, Dr. Kelan Tantisira, who will help to kick off our discussion and response portion of our webinar. Our first presenter today, Dr. Suchitra Rao. Dr. Rao is an associate professor of pediatrics at the University of Colorado and an infectious diseases physician and hospitalist with the Children's Hospital Colorado. Dr. Rao will be presenting on the clinical features and the burden of PASC in children and adolescents. And then next, we'll hear from Dr. Vitaly Lorman. Dr. Lorman will share more on how Recover investigators are identifying pediatric long COVID in electronic health record data. Dr. Lorman's a data scientist at PedsNet in the Applied Clinical Research Center at the Children's Hospital of Philadelphia. His background is in mathematics, and he received his PhD from Johns Hopkins. And his prior position, he taught and conducted research on topology as a visiting assistant professor at Swarthmore College. And then we'll wrap things up and hear from Dr. Kelan Tantisira, who will help to lead off our discussion starting with a brief synthesis of these presentations and a short series of questions to our panelists. Dr. Tantisira is a professor of pediatrics and chief of the Division of Pediatric Respiratory Medicine at the University of California, San Diego, and Rady's Children's Hospital located in San Diego. So following our discussant, we'll open the floor to questions from our audience. And as mentioned, we're going to try and answer as many of those questions as possible for today's topics and presentations. So please drop your questions in there. And I'm pleased to welcome our speakers as we turn things over to Dr. Rao.
Great, thank you so much, Christine. And thanks so much for you and your team for inviting us to speak with you today. And thanks to everybody who's joining. So we're really excited to be here and just wanted to share with you some of the work that we're doing with the pediatric side of the EHR cohorts. So if we can go to the next slide. The work that we're going to be presenting to you today is work that is funded by the NIH's Recover initiative. So I wanted to give you a little bit of context in terms of sort of where we fit within all of the different elements and arms of Recover. And then the work that we're going to be presenting are just a couple of our published studies, and looking forward to sort of any questions that might come up about how we do this work, how this work sort of relates to pediatrics, and we'll sort of see where our discussions take us. So if we go to the next slide. As I'm sure you're all very well aware, the pediatric community and research community at large have really acknowledged that we need to understand a lot more about the long-term sequelae of long COVID in children. And I feel like that a lot of this research is still in its infancy. We know that children experience long COVID just like adults, and we know that they may experience it in different ways, given that children across all the different age spans may have different manifestations. And so it's important for us to think about this population of children, and make sure that we recognize that things might be different. They might present with different incidences, and they may look different from how these are all presenting in adults. And there's been a wide variation in just how often we see this in kids. You may remember some of those earlier reports were looking at incidence rates, something into the 40 to 60% mark. And then more recent studies might be showing different estimates. And one of the reasons why we're seeing this wide variation is because there's such heterogeneity in how we approach this topic. There's differences with case ascertainment, with methodology of existing studies, and some of these studies will not have an appropriate comparison group. So it's very difficult to study something where you might see manifestations in people without the infection as well. And so in response to this need to be able to better characterize PASC in children, a group of us, data scientists, researchers, clinicians at PedsNet, and the group of us that are working within the pediatric EHR cohort formed a network to try to help answer these questions. So if we go to the next slide. So I wanted to give you a little bit of background about PedsNet. So this is the group that is sort of really leading the work on the pediatric EHR cohort side of Recover. So PedsNet originated from 8 founding institutions and has created a longitudinal data resource dating back to 2009. And it cuts across all sorts of different pediatric diseases and all sorts of different pediatric specialties. PedsNet, the work that we're going to be presenting incorporates the institutions that you see here. So these are all large pediatric health systems across the country. There are additional sites that are a part of PedsNet and are also going to be onboarded shortly. So PedsNet is a research network within PCORNet. And so you heard from Dr. Tom Carton and others a number of weeks ago about some of the work that PCORNet was doing to answer questions around adult PASC. And we are essentially the pediatric branch of that, looking to answer questions focused in pediatrics. So if we go to the next slide. Just wanted to give you a little bit of background about the data that we are using and just how we kind of have all these, this network come together. So essentially we use a common data model that standardizes our data into a single language. And by being able to do that, then you're able to pull these data from across all these different networks very efficiently and cleanly and effectively to be able to answer questions at scale and at speed. There are a lot of data verification steps to ensure that the data is of the highest quality. And some of the data that you see includes things like diagnoses, includes medication information, it includes lab values results, it includes demographics, we have procedure information, we are pulling in social determinant of health, geocode data, and then now we're really starting to get better at pulling in unstructured data, including natural language processing data and text from notes. If we go to the next slide. So PedsNet captures data for approximately 12 million children. It represents about 14 different different hospitals across 11 network partners. And that includes 357 primary care practices, 73 community clinics, and 41 emergency departments. And annually, it represents about 10% of the nation's children. And if we go to the next slide. So just in terms of how this all fits within Recover and its pediatric focus. So the Recover initiative, as you recall, is really comprised of these 4 cores. And a lot of the work that is being done can be broken down into the prospective collaborative cohorts. And so these are the ones that are enrolling patients during the observational cohort studies. And then the other branch of Recover is the EHR or health systems branch. And that is going to be utilizing on the pediatric side close to 9 million different records and includes cases of confirmed COVID infection, those that have sort of long COVID diagnosis codes, as well as control subjects who don't have evidence of infection. If we go to the next slide. So using this very rich pediatric data source, we wanted to answer the following questions as it relates to children. So firstly, what are the features of PASC that we're seeing in children? Secondly, what is the estimated incidence or prevalence of PASC in children? And then finally, what are some of the risk factors that we're seeing in children? Is there a way that we might be able to sort of predict who might go on to have long COVID? So if we go to the next slide. So for this project, we included individuals who were under 21 years of age who underwent a SARS-CoV-2 PCR test. And we really wanted to make sure that we captured an active population that was having and seeking healthcare at one of these PedsNet sites. And so we really just restricted our population to those who had at least one healthcare encounter in the prior 3 years to really better define this active population. And so then in terms of the timing of when we were evaluating some of these outcomes, we looked at the window of time in the 1 month to the 6-month period after the cohort entry date. And that was based on the timing of that first SARS-CoV-2 test. So we had a group of patients that we would call the exposed group, so evidence of a SARS-CoV-2 positive test. And we had an unexposed group, which was those that were testing SARS-CoV-2 negative. If we go to the next slide. And so the approach that we took here is essentially looking at different features of PASC. So we broke them up into syndromic features, and that really just is looking at different symptoms associated with PASC. So things like fever, fatigue, shortness of breath, palpitations, etc. And we looked at systemic features, which were really conditions that we have been seeing in the literature emerging as being associated with long COVID. So these are things like myocarditis, myositis, asthma, and we used a washout period, and that's just a technique that we will employ to try and just capture those sort of incident conditions. So we know that some of these features can be found in people who don't have evidence of COVID infection. So we really wanted to find out ones that were sort of developing after someone was diagnosed with SARS-CoV-2. And then for these analyses, we also took what we called a clinician-driven approach as well as a clinician-agnostic approach. And so when we did our work on the clinician-driven side, we had a big team of subject matter experts, so subspecialists, pediatricians, and other health partners that were subject matter experts in various components of long COVID. So pulmonologists, infectious diseases docs, ICU docs, etc. So we had a clinician work group that were pulling lists of symptoms as well as conditions that have been known to be associated with long COVID, either based on personal experience as we were getting more information accruing, or based on what we found in the literature. And so we developed these sort of lists of known sort of features to be associated with PASC. So we looked at these, we had a clinical adjudication, we figured out ones that we considered to be clinically meaningful and biologically plausibly related to PASC. And so that was what we comprised as the clinician-driven approach. The clinician-agnostic approach took a list of these ICD-10 codes, and whatever wasn't sort of put into that category of clinician-driven then became clinician-agnostic. And this was an approach that we took so that we could do some discovery as well. So rather than just relying on sort of our clinical knowledge base, we wanted to see if there were any additional sort of signals in the EHR data that could be sort of useful and meaningful. So we started out with an AHRQ list of codes. So as I mentioned, we had over 66,000 codes that we started with, and we reduced those down to 441 relevant clinical features. And our evaluation period was patients who were seeking healthcare at one of these PedsNet sites from March 1st of 2020 through till October 31st of 2021. And so when we looked at that cohort, we had over 660,000 patients who underwent a SARS-CoV-2 test by PCR across all of the different sites, and who had at least one prior visit in that 7 days to 3 years prior to their test date. And then of those patients, a little under 59,000 of them were positive for SARS-CoV-2. So that was a positivity rate of about 9%. And so if we go to the next slide. So what I'm going to show you now are just some of the results. So the next 2 slides are going to show you just a table of figures that, just a table that's going to be comparing those who are SARS-CoV-2 positive with those that are SARS-CoV-2 negative. So if we look at this table here, patients who tested positive were more likely to be of older age, to be of Black race, and to be of Hispanic ethnicity. And if we go to the next slide. And on this table, this is looking at some of the underlying medical or chronic conditions, the time period of cohort entry, and then the test location. And here, the majority of patients were tested in an outpatient setting or in an ambulatory setting. And then a higher proportion of those inpatients who were tested were test negative. And if we go to the next slide here. So the way that we wanted to explore different associations with long COVID is we wanted to look at how often something occurred in the population of patients that were test positive compared to or relative to those who were tested negative. And the way that we did this was to use adjusted hazard ratios. So what you're going to see over the next couple of slides are forest plots that show you the adjusted hazard ratios that are plotted. And so the further you are to the right, the stronger the association. And then if you see something that is overlapping with one, that line, it sort of overlaps on that line, then that may not be considered significant. And so again, we are looking at that ratio then of testing positive, having a feature amongst the positive group compared with those who tested negative. And we'd used an adjusted hazard ratio model, and we adjusted for things like site, for age group, for sex, for race and ethnicity, as well as the time period of the cohort entrance, as well as the location of testing. And so what we're just going to show you on these slides are those that are clinically relevant and statistically significant based on our findings. So in terms of the symptoms associated with PASC, in order again from the strongest association down, we identified the following features. So we found changes in smell and taste, loss of smell, alopecia or hair loss, chest pain, abnormal liver enzymes. We found generalized pain conditions, as well as anxiety symptoms. There were some signals for skin rashes, for persistent fever and chills, as well as cardiorespiratory symptoms. And then if we go to the next slide. So this was the forest plot looking at various conditions associated with SARS-CoV-2 infection. And so in terms of some of our systemic features, we identified myocarditis to be a very strong signal, acute respiratory distress, as well as myositis or muscle inflammation, visits for mental health treatment. We found other ill-defined heart disease, thrombophlebitis or thromboembolism was strongly featured as well. And we found some associations with some respiratory and sort of upper respiratory tract infections as well. So if we go to the next slide. So now we know that estimating the incidence of PASC can be sort of challenging, and I mentioned very heterogeneous across different studies. So in our attempt to try and get a sense of the incidence of PASC in this cohort, we looked at the incidence proportion difference. So the way that we did this is we looked at the incidence for any clinically predicted or empirically supported symptom or condition or medication related PASC feature between those children in the SARS-CoV-2 PCR positive group, and then compared that with those who were in the test negative group. And so we, as you can see from this table here, the incidence in the test positive group was close to 42%, compared to around 38% in the test negative group. So that gave us an incidence difference of 3.7%, so close to 4%. And then if we go to the next slide, we also evaluated risk factors for PASC, and in our adjusted hazard ratio models, we found some of the strongest associations for PASC to be in those who were admitted to the ICU for their acute illness. We found a strong association for children under the age of 5 in terms of PASC that was sort of presenting to medical care, as well as those with a chronic complex medical condition. Now, if we go to the next slide, now it is worth highlighting some of the limitations of using EHR data for this type of work. So we looked at symptoms and signs and other diagnoses that were significant enough to prompt health service use. And so we may not be able to capture all of the different manifestations of long COVID in children. The burden of PASC may be underestimated from EHR data sources. And one of the reasons for this is the issue of misclassification. So what can happen is we're really just able to see those tests that occur at the health systems themselves. And so if something was taking place at a different health system with respects to testing, or if all of the testing was done sort of with at-home testing, then there may have been some misclassification. And that might explain why we saw sort of a low incidence proportion difference in this cohort. And it's also worth pointing out that this work was done before home testing was widespread. So that is probably a little bit less of an issue with sort of our time period of our data. And the other important point here is that some findings may reflect differences in care-seeking behaviour as well as access to care. So if we go to the next slide. So just to summarize this work again, in this study that we published evaluating the PASC features in close to 660,000 children undergoing testing for SARS-CoV-2, we found that there were features that overlap with some of what we're seeing in the adult populations, but there are other features that are maybe less well reported in adults that we're seeing in kids. And so some of the more common symptoms and common conditions are shown for you here. And this really is one of the things that highlights why having a control group is really important when you're doing these types of studies. And we also looked at some risk factors for PASC that was resulting in health-seeking behaviour. And so we found associations like having underlying medical complex conditions, being in the ICU for the acute illness, as well as those who were under the age of 5 years of age. So if we go to the next slide. So I wanted to conclude there, but then I really wanted to make sure to acknowledge all of the folks that were engaged in this work, that were representing the PAEDSnet sites and our subject matter experts. So we had representatives from each of our PAEDSnet sites, and I also wanted to thank the team at the CHARP Data Coordinating Centre, including Vitaly, Lorman, who's here today, Chris Forrest, Charlie Bailey, Hanya Razagi, Ryan Webb, and Kimberly Dickinson for all of their work on the analysis and data science. So with that, I'll pass it over to our next speaker, and looking forward to discussions afterwards.
Great, thanks, Dr. Rao. So next we'll move to our presentation by Dr. Vitaly Lorman. As a reminder, if you have a question for any of our panelists, please drop them into the Q&A feature located at the bottom of your Zoom window. It's great to see those questions coming in, and we're looking forward to having the opportunity to respond to some of those. Thanks. Dr. Vitaly.
Thank you so much for the invitation to speak here. I'm very excited to tell you some more about work that's been going on in PAEDSnet and as part of Recover on pediatric long COVID and to the subsequent, looking forward to the subsequent discussion. I'm going to talk a little bit about kind of how we identify, how we've been working on identifying pediatric long COVID in EHR data. But first, I want to say a little bit about why, we think this question is important. I think there are really two answers. One is that, identifying long COVID in EHR data goes hand in hand with finding out what long COVID is, how it presents in children, what are the associated symptoms, conditions, kind of clinical trajectories, those kinds of things. And additionally, being able to provide some answer to this question is kind of necessary if you want to conduct other studies about long COVID. For example, if you want to identify long COVID subtypes, look at the effectiveness of various treatments, look at how long COVID has changed over time, and other studies that involve a definition of being able to identify patients who are likely to have had long COVID. Next slide, please. So, kind of the first approach you might take if you want to identify a cohort of patients who were likely to have had long COVID in EHR data is you might want to see, who was actually diagnosed with long COVID. And there are actually three relevant diagnosis codes in the ICD-10 vocabulary here. The first one is U09.9, which you may have heard about if you attended the corresponding R3 seminar for the adult EHR group. So that's for post-COVID-19 condition unspecified. And that code was introduced in fall of 2021, so about a year and a half into the pandemic. Additionally, there's a diagnosis code for something called multisystem inflammatory syndrome in children, which is a condition that drew a lot of attention, especially earlier on in the pandemic. It tends to be kind of very high in intensity, maybe with treatment shorter in duration. And the CDC characterizes that as inflammation following COVID-19 and roughly manifesting in at least 2 body systems. And because MISC is sort of so specifically defined, we often tend to sort of separate it in analyses. So the study I'll be talking about today, we focused mainly on non-MISC presentations of long COVID, although then in other studies that I'll talk a little bit about at the end, we kind of treat them all together. And then finally, there's another diagnosis code that is not specific to COVID, this B94.8 sequelae of other specified infectious and parasitic diseases code, which predates the pandemic, and it was recommended for use prior to the U09.9 code being introduced. And so, you might start by looking at patients who are diagnosed with these codes. But there are some limitations in just using these diagnosis codes, which have to do with how and when these codes tend to be used. So for example, these codes just didn't exist earlier in the pandemic, so you're unlikely to be able to find patients who had long COVID earlier in the pandemic using these codes. And then furthermore, we're limited by the developing clinical understanding of what long COVID is. And so, and how it's involved over time. And so there might be specific settings such as long COVID clinics where these diagnosis codes tend to get used more, and maybe specific providers where they get used more, and other settings where they get used less. And so because of that, there's good reason to think that just looking at these diagnosis codes alone is likely to significantly under ascertain who has long COVID in EHRs. And so, the next thing you might try to do is move beyond that by identifying who has long COVID using other data elements in the EHR. Next slide, please. And so the question you then might want to ask is, what symptoms and conditions are more common in patients who have long COVID, which I'll also refer to as PASC, post-acute sequelae of COVID-19. So what symptoms and conditions are more common in patients with PASC? And so, to ask what is more common, you have to make a comparison to another group of patients. And there are 3 relevant comparisons here. You can look at patients who are diagnosed with PASC and compare them to patients who have COVID, but not PASC. You could compare them to patients who didn't have COVID and in fact had a negative SARS-CoV-2 test result. And finally, you can compare not just patients who have been diagnosed with PASC, but all COVID positive patients, patients with COVID, compare them to patients without COVID. And these are all important comparisons, and there are subtle differences in them that kind of all make them worth studying, and they point to different things. For example, in the third comparison, SARS-CoV-2 positive patients, looking at that comparison has the advantage of looking at a much larger group of patients. There were a lot more patients who had COVID than those who had long COVID. But on the other hand, patients with COVID-19 are a much more heterogeneous population for the reason that in the EHR, someone may have gotten a COVID-19, a SARS-CoV-2 test, not because they came in for that, but incidental to something else that they were seeking care for. And so it's going to be a much more varied population. And so in this study, our main analysis focused on the first two comparisons, and then we did the third one as sort of a sensitivity analysis, and then we tried to synthesize and investigate all of those. Next slide, please. Okay, so just to draw a little bit more attention to this idea that patients who are diagnosed with PASC might not be representative of all patients who may have had PASC or long COVID. So this shows in our study patients who were diagnosed with PASC compared to patients who just had COVID. And what we see looking at this table briefly is that patients diagnosed with PASC tend to be generally older than patients with COVID. So they're more likely to be in the age 12 to 15 or age 16 to 20 in those age groups. They're a little more likely to be female. They're more likely to be non-Hispanic white. And in terms of presence of existing chronic conditions, we see that patients diagnosed with long COVID are more likely to have both chronic conditions and more likely to have complex chronic conditions, where we categorize this using something called the pediatric medical complexity algorithm. And just to give an example, asthma is something which would be considered a non-complex chronic condition, and complex chronic conditions are ones that are progressive or malignant or affect multiple body systems in this categorization. So we see that patients who are diagnosed with long COVID do tend to differ substantially in several respects from patients who have COVID. And there are several hypotheses for this. For example, it might be that that patients who, in younger patients, there might be certain symptoms, for example, persistent cough, that you would be more likely to attribute to early childhood illness, whereas in older patients, you might be more likely to attribute them to COVID. And they might also have a lot to do, as I mentioned before, with who has access to long COVID clinics, access to care, those sorts of things. And so again, this is sort of a case for moving beyond just the specific diagnosis codes for long COVID and trying to come up with a more broad definition of what long COVID is to try to capture a broader cohort of patients in electronic health records. Next slide, please. So I'll start now to talk more specifically about this study. So in order to, in EHR data, which is secondary use data, whenever you make a comparison between two groups of patients, there's always the chance that there are incidental differences in the two groups. For example, having to do with who came in to get to have a COVID test recorded in the EHR, or who happened to have a PASC diagnosis recorded in the EHR that might not actually have anything to do with the comparison you're trying to make. They might not have anything to do necessarily with PASC or COVID itself, but instead other differences in healthcare utilization. And so because you don't want those to give you false signals in your results for what you're looking for, sometimes, so in this study, we use the method called matching, which the idea behind it is to try to control for those differences, so sort of to try to simulate or emulate a randomized control trial. Next slide, please. Okay, and so once we had our cohorts defined, so we're comparing patients who were diagnosed with non-MIS-C PASC, and we're comparing them to both patients who had COVID-19 and who weren't diagnosed with PASC, and to patients who did not have COVID-19, defined as presence of a negative SARS-CoV-2 test. So we're making those two comparisons, and the outcomes we're interested in, there are many of them. We're interested in seeing exactly what symptoms and conditions are diagnosed disproportionately among patients with PASC compared to our two control groups. And so there are lots of possible diagnosis codes that can occur. As Suchitra's slides showed, there are nearly 70,000 different ICD-10 codes. And so we're kind of scanning the entire set of possible ICD codes, diagnosis codes, to see which ones occur disproportionately, more frequently in patients diagnosed with PASC. Now, diagnosis codes don't live in isolation. Instead, they're part of a complex hierarchy. So the image in this slide shows underneath, so that within the ICD hierarchy, there's a branch that consists of codes that start with the letter R, which are symptoms and signs and abnormal findings not classified elsewhere. Underneath that, there's a branch of codes that start with R00 through R09, which are symptoms and signs involving the circulatory or respiratory systems. And this chart here just shows like that sub-branch of the ICD hierarchy, just to give an example. And so the method we use, called a tree-based scan statistic, it scans this entire hierarchy, and it looks for both individual diagnosis codes, but also clusters of diagnosis codes, so branches of this hierarchy, which is also called a tree, in which diagnoses in those clusters were disproportionately likely to occur in patients diagnosed with PASC compared to our control groups. And the advantage of this approach is that it can identify not only specific codes, but also clusters of codes. So it can sort of identify for you the varying levels of granularity at which we see PASC manifested in EHR data. And then given those findings, you can then kind of comb through them and figure out at different levels of granularity which codes you want to look for and maybe incorporate into your long COVID definition that you want to apply to EHR-based studies of PASC. Next slide, please. Okay, so now I'll just summarize at a high level some of our results. Because we were scanning so many codes, there are a lot of results here, and there are also, you can find more detailed descriptions in our manuscript. So this slide shows systemic findings. So one's related to organ system function generally, and then the next slide shows syndromic findings. So one's related to symptoms. And so just to give start with a high level summary. So a lot of what we found is consistent with other studies. At a broad level, we found diagnoses associated with PASC in cardiac, respiratory, neurologic, psychological, endocrine, gastrointestinal, and musculoskeletal systems. And then just to highlight a few, we saw neurologic disturbances like headache and migraine recurring. We saw sleep disturbances like sleep apnea, which was the subject of a recently published Recover manuscript. In the musculoskeletal system, we saw multiple and diverse pain symptoms, such as pain in joints, pain in limbs, soft tissue disorders, that we think are worth further study, in particular in terms of the underlying biological mechanisms. And I didn't mention, but we were looking specifically for new diagnoses that occur during the post-acute period. So in other words, we were interested in diagnoses that occurred for the first time, at least in the previous 18 months, for the first time after the patient had COVID or had PASC diagnosed. And so what that means is, for example, when we see asthma codes, specific asthma codes show up in our findings as statistically significant, that points to perhaps new onset asthma being associated with PASC. Of course, it's also possible, and this is where things get kind of complicated, it's also possible there were patients who had asthma prior to having a PASC diagnosis, and with PASC, perhaps their asthma was exacerbated to the point where it was recorded in the EHR, but it wasn't previously. And so, disentangling these kinds of things, as we might get into later in the discussion, is one of the more complicated parts of interpreting these findings. And finally, compared to previous work, including the study that Suchitra discussed, there was a lot of overlap, but we also found some differences that are worth noting. Abnormal liver enzymes, allergies, disorders of teeth, and bronchiolitis were all reported as potential PASC-associated features in the study that Suchitra led, but we did not see those as significant, statistically significant in this study. And conversely, significant findings in our study that were not present in the study that Suchitra presented included sleep disorders, anemias, eye disorders, constipation, nutritional deficiencies, hypotension, and various musculoskeletal conditions. And what all of that means is really that, it's worth looking at what conditions and symptoms are associated with PASC from a variety of perspectives and trying to synthesize those findings. So we expect to see, depending on what comparisons we make, how we define our cohorts, and during what time period of the pandemic we look at these things, we expect to see different results, and those differences themselves may be interesting and worth further investigation. Next slide, please. So this slide shows specifically symptoms that were significantly more likely to occur in patients with PASC compared to our control cohort. Next slide, please. And then briefly, I just wanted to show a small sample of the more granular output of our analyses. So as I mentioned before, this tree-based scan statistic approach, what it does is it looks for where there are signals, in other words, where patients with PASC disproportionately tend to have diagnoses in this complex ICD hierarchy at different levels of granularity. And so this shows just a small snippet of it where we see that, for example, the R00 to R09 branch, symptoms and signs involving the circulatory and respiratory systems. In general, there were diagnoses in this branch tended to occur more often among patients with PASC, but then it also points to specific codes within those clusters that might be especially driving it. For example, dyspnea, malaise and fatigue, et cetera. And so there's a very large table in our manuscript, and as you scan through it, you can kind of find where signals were detected at more general levels and where they were detected at more specific levels. And there's a lot there that might be worth investigating further in terms of what symptoms and conditions might be associated with PASC. Okay, and then the other finally, the other reason that these more granular findings are interesting is that then they give you a way to try to define what PASC is in EHR data. Next slide, please. So both the study Suchitra spoke about and the work that I've been speaking about feed into the process of developing a set of rules or an algorithm, also called a computable phenotype, to identify which patients have PASC in EHR data. And there are two approaches that we've taken to this, both of which are ongoing. One is a rules-based phenotype. In other words, it's a set of rules based around specific lists of diagnosis codes and rules around when and under what circumstances those codes occur in order to say that, with some probability that a patient might have PASC. And additionally, we've employed a machine learning-based approach, which involves training a model to classify in EHR data which patients resemble those who are diagnosed with PASC based on input data that's selected from these tree-based scan statistic selected features that we presented in this study. Next slide, please. So just briefly, our machine learning phenotype, it draws on the inputs it draws on are not just conditions, but also procedures, laboratory testing, and prescribed medications. And one advantage of it is that it outputs probabilities. So it gives you some level of confidence that a patient, in its classification, that a patient may have had PASC. Another advantage of machine learning methods is that they can pick up on very complex patterns that involve a lot of different specific inputs that are very hard to notice just by looking at the data. But the downside is it depends a lot on the data the model is trained on. And in particular, the model we used was trained on both MISC and non-MISC PASC diagnosis codes. And if those codes are not representative of what PASC is, which there's good evidence to think they're not, this is a limitation that can be inherited by the model and we have to be aware of. And for that reason, another approach we've taken, on the next slide, please, is developing a rules-based phenotype for PASC. So The rule set looks both at the specific diagnosis codes, U09.9, and the MISC diagnosis code, M35.81, which I spoke about initially. But the rule set also looks at patients who had COVID, and then in the post-acute period, 1 to 6 months following acute infection, had diagnoses in one of several clusters of PASC-associated diagnoses, which were put together by combing through the output of the 2 studies that you've heard about today. And so where we are with this phenotype is we're in the process of doing chart review validation, which means that chart review expert adjudicators are actually, for a sample of patients, looking at patients' charts and seeing whether, when our algorithm says that a patient was probable to have PASC, whether the clinician who was seeing the patient agreed with that, or whether they perhaps attributed the symptoms to something else that we didn't pick up in the EHR. So we're in the process of summarizing the findings from chart review, and then next steps will include further refining this algorithm to better capture who has long COVID in EHR data. And finally, next slide, please. I thought I would conclude just by pointing to a few other studies that are in progress, either in the form of preprints that have been submitted, or manuscripts that are currently being written, or studies that are just being planned that build on some of this work. We've been working on identifying what are the distinct subtypes of PASC. We've been looking at exacerbation of existing chronic conditions such as diabetes and asthma and others. And we've been looking at temporal trends, trying to see how has long COVID changed over the course of the pandemic. Additionally, we've looked at effectiveness of certain treatments and other topics that all kind of interact with one another. So thank you so much for listening. I will stop here and looking forward to the discussion.
Great. Thank you, Dr. Lorman. And thank you, Dr. Rao, for sharing these complex findings with everyone today. And we're going to dive into these questions here. Special thanks to those of you who have submitted those questions. And with the time remaining, which we're about halfway through, which is great, we will be able to get to a number of those. But first, I'd like to bring in our discussant, Dr. Tantisira, to give us a brief synopsis to connect these 2 presentations. And you get first dibs also on the questions to presenters as well. So Dr. Tantisira.
That's exciting. So these have been absolutely tremendous talks, and I appreciate both Dr. Rao's and Dr. Lorman's presentation. I did want to give a brief synopsis from my take on these 2 talks. And as a respiratory epidemiologist, I found it very fascinating the way that electronic health records data can actually be modeled multiple ways from an epidemiologic perspective. So for instance, Dr. Rao actually presented her data more in a prospective, or actually retrospective, but incident cohort type of approach, where she gathered everybody up front and they followed them over the course of time to really look at incident symptoms and conditions. And so, that's really more of a traditional epidemiologic cohort. And it's great to see that these types of studies can actually incorporate that. And Dr. Lorman actually identified more of a traditional cases and controls up front to say, here, these are the individuals that we can identify with PASC and compare it to a matched group of COVID positive individuals and COVID negative individuals in the 5-to-1 matched case to control. He did not present one thing that I would be fascinated by, potential risk factors in doing a traditional case control type of analysis, but I'm sure that he may have some of that data there. And to further summarize Dr. Rao's presentation, in addition to doing this cohort type of approach, she actually looked at 660,000 patients, 59,000 with SARS-CoV-2 positive status at that point in time. And she reported a variety of interesting hazard ratios with top symptoms, including changes in smell and taste, and others with marked increased hazard ratios of greater than 1.5, including hair loss, chest pain, and elevated liver enzymes. And then she also looked at conditions that were associated with PASC, including myocarditis, ARDS, myositis, and mental health treatment, all with significant elevated hazard ratios of 1.5 or above. And then she very nicely went through calculations for how many of these do we believe are truly incident for PASC themselves as compared to other conditions by comparing incident proportion differences and detailing specific risk factors for the reported PASC as well, including ICU admissions, age less than 5, and chronic complex conditions. Dr. Lorman, as we mentioned, took a more of a let's cluster these together, do a 5-to-1 matched cases to controls based on diagnostic codes. And gave a really nice presentation on how to enhance the potential for those diagnostic codes into relevant clusters that may represent PASC, a long-term outcome. He evaluated 1,300 patients with PASC and did a 5-to-1 case to control matched cohort design. And then he carefully reviewed the major systemic and syndromic findings, providing diagnostic codes associated with PASCs to try and kind of highlight enriched populations. And obviously, as a pulmonologist and respiratory epidemiologist, I was fascinated by the fact that many of his findings actually did point to respiratory conditions, including one that I didn't know was enriched, which is obstructive sleep apnea. So thank you for pointing that out to me as well. And then he further went on to define, how do we take this forward in terms of using machine learning and rules-based algorithms, and concluded with other fascinating work. And love the idea of looking at disease subtypes, for instance, and the effect of chronic conditions on PASC. So I do have a few questions for you guys up front, and would love to, obviously, we'll leave plenty of time for the audience to ask things. I'll start with Dr. Rao. You presented several or 2 slides looking at hazard ratios, one which was for symptoms and one which was for conditions. And there were some conditions and symptoms that seemed to overlap to me on just initial look at them. And for instance, symptoms can include things like chest pain and cardiorespiratory symptoms and respiratory failure. And those tended to be much more modest in terms of those hazard ratios, all kind of 1.5 or less as compared to conditions, And so, for instance, when I think as a respirologist, respiratory failure 1.16, and then you have something like acute respiratory distress syndrome, and those hazard ratios are much larger, close to 3. There seem to be some differences there. So could you explain perhaps what elements in your study contributed to those reported differences between symptoms and conditions?
Yeah, thanks for that question, and just sort of your astute reviewing of those different hazard ratios in those 2 groups. Yeah, we were sort of struck by that too. And I think some of it has to do with the way that some of these data are sort of coded, or some of these diagnoses are coded, and may just have to do with some of our analytic approach. So for example, when we looked at the conditions and we were calculating those adjusted hazard ratios, we did exclude those who had pre-existing conditions in that sort of 7-day prior to the test and going back 12 months. That way we would just kind of look at things that were associated with, potentially associated with having acute COVID versus an underlying comorbidity that you had. And so that could be one reason to explain why we were seeing a little bit more of sort of more striking hazard ratios in the conditions versus the symptoms. There could also be something around the coding of some of these. So we know that coding is probably going to be a little bit more specific for conditions versus symptoms. Not all symptoms may be sort of coded for different types of visits. So those could be a couple of explanations.
Great. And Dr. Lorman, I think this is actually more of something that you alluded to, but I think is a key portion of the clarification of your approach. And so you mentioned that your models may be limited if the diagnostic codes are not representative of PASC itself. And we get to this idea of pre-existing disease. For instance, I see a lot of asthmatic patients in my clinic. And so if one of my patients would come in with worsening shortness of breath following, in the post-COVID era, have you assessed whether I, as a pulmonologist in my EHR, might be more likely or less likely potentially to call this PASC instead of relating it specifically to asthma?
Yeah, it's a great question. So I think there are multiple answers here that kind of point in different directions. So on the one hand, we know that patients with existing chronic conditions are more likely to have a PASC diagnosis in the EHR. So that's one part of it. On the other hand, we also know there are a lot of patients, both with existing chronic conditions and without existing chronic conditions, who have PASC, symptoms and conditions that are associated with PASC in the post-acute period who don't receive a PASC diagnosis. And I think, in our work on phenotyping, on developing a PASC phenotype, I think one of the hardest things has been figuring out how to detect attribution. So how to figure out whether, a diagnosis that occurs in the post-acute period, whether it's actually due to something that, the patient had prior to having COVID. And, even if it was something they had prior to having COVID, whether it was, something that was like their underlying condition was exacerbated by COVID, which we would still consider, part of PASC, or whether, it was just their normal course, normal trajectory, kind of irrespective of COVID. Yeah, so attribution is really difficult. We're hoping that, the chart reviews that we're conducting can shed more light on this. We're also using methods from natural language processing to look at note data to see what, cases where in the chart notes, symptoms have been attributed or not attributed. And then I should also finally say, we did, in a preprint, we did take a look kind of broadly at among patients with existing chronic conditions, their trajectories following COVID. So we compared a cohort of patients with chronic conditions who had a positive COVID test to those who, patients with chronic conditions who had a negative SARS-CoV-2 test. And we did find increased utilization along many different, for many different kinds of chronic conditions. But, we think that there's a lot more to investigate there that depends on the specific condition. So for example, we've looked at trajectories of patients with diabetes over time before and after COVID. And we've done a little bit of preliminary work with asthma too. So yeah, hopefully there'll be more in the future. But I think, the short answer is that exacerbation of existing conditions and what's attributable to COVID and what isn't are some of the hardest things to disentangle in EHR-based studies.
Right. So I have two additional questions before we open it up to a broad chat. And I'd like both of your perspectives on these following questions. We just heard about trajectories. And we looked at, PASC as outcomes. Have you looked at more longitudinal assessments following a diagnosis of PASC to evaluate what the natural history of PASC might be?
Yeah, that's a really great question. I can start, and then Vitaly, feel free to add to that. I think it's a really important question. We're all really keen to know how long, if someone is going to get PASC, how long do they have it for? Are we noticing any differences in kids compared with what we're seeing and reported for adults? Can we glean anything from EHR data sort of while we're enrolling our prospective cohorts into the other arm of Recover? So we did try to look at some of that in the work that I just presented to you, where we were just looking at sort of patterns or events over time and who still had an event after a certain period of time. So this was, it can be very challenging to do this type of work with EHR data. We've talked about some of the limitations. I think that we are sort of at the mercy of when something is present, when something is sort of coded, then we can say, okay, we know this is present. But when something is no longer present, is that just because people are dealing with it and not seeking healthcare, so we can't capture it, or is it truly recovered? And so that's why we might have some limitations looking at that in EHR data. But so with that caveat, we did look at some of this sort of time to recovery with our data set. And I recall that around that 6 week mark, the 6 month mark after having a positive test, about 40% of patients still ended up having some sort of PASC feature. So again, I think there's sort of more work that we need to do in this space, taking into account some of those limitations. But other reports in the literature talk about recovery for kids in general being a little bit shorter than in adults. But of course, we all know, and we've taken care of kids and have seen, had experiences of children who have symptoms much longer than that.
Yeah, I think just to add a little bit, so I think, yeah, this is definitely an area where there are a lot of interesting questions, and I think there's a lot more we could do. In our work on PASC subtypes, we've been looking at kind of patient utilization in each subtype before and after having COVID to see whether there are groups where, there's sort of a return to normal versus even after 6 months, whether patients still have increased utilization by different measures. So that's one thing we've looked at. In patients who had diabetes, in kids with type 1 diabetes, we've looked at hemoglobin A1C trajectories kind of before and after COVID. So that's a preprint. But, roughly there, the findings were kind of inconclusive, but if you look at just the plots of the trajectories, we sort of see hemoglobin A1C values among patients who had COVID go up and then come back down, go up around the 3-month period and then come back down around 6 months. So we have definitely been looking at trajectories. We've also looked at, the history of PASC itself as an entity to see how manifestations of PASC have changed over the course of the pandemic. That's something we're, in the progress. That's a study that's in progress. Looking at, for example, at the hypothesis whether, has PASC since Omicron has long COVID, have its manifestations become more respiratory in nature. So those are some of the things we're currently looking into, but I think there's definitely a lot more to be done.
Right, thank you. My final question for both of you is, I think this is something many people are interested in, but as I in addition to who I am in terms of my position, I'm also one of the Recover main site PIs, and we're actively recruiting patients into the main cohort. And I think a lot of folks are really trying to ascertain what are we going to do with the main cohort data, and how can we optimally use it as we start to look at it. What are your thoughts about, as we begin to analyze the data from the main cohort, how can we best use your EHR data to support and validate those main cohort findings, or vice versa? How can the main cohort findings better inform the work that both of you are doing going forward?
Yeah, it's really a great question. Thanks for posing it. And I do agree. I think that there's a lot of opportunity for us to be sort of cross-collaborative, and that the work that we do can inform the prospective work and vice versa. And so I think there's a sort of number of ways. I think one of the objectives that we're really going to be focusing on in some of our future work is sort of this concept of help with trial recruitment. So there is overlap with the EHR sites and the prospective trial sites. And so there's an opportunity for us to develop, validate a computable phenotype where we can identify patients that have PASC based on what we sort of have seen and gleaned from the EHR, that we can use then as sort of a population that can be screened to see if they do indeed have symptoms of PASC, ongoing symptoms of PASC, and then could potentially be recruited into some of these studies. So I think that's something that people are really wanting to pull resources and look into for the upcoming year. I think that something else that can really be helpful is, I think of EHR as a great way, as EHR data as a great way to do sort of hypothesis generation and signal identification. So if doing some of these sort of machine learning unsupervised analyses, if we do find signals in the data, then that is something that can then be sort of validated or measured or about, explored further with the prospective cohort. So it might inform study design, it might inform what type of patients should be enrolled. So I really think that has been super helpful. I'm looking at some of this in my work, where we might find a signal, and then I now want to explore this in my other work, looking at sort of the mechanistic aspects of long COVID in kids. I think another thing that we could potentially do is we have such a depth, there may be other conditions that we haven't talked about today that are presenting in children. Someone had mentioned, neuropsychiatric findings or tinnitus or some sort of things that are reported that have been seen. But if we want to explore that further, EHR data sources are a great way to try and find those patients. And then we can, again, sort of help to figure out, is there an opportunity for them to be sort of enrolled in trials, or are there specific questions that we can answer now that we've pulled and found kind of a cohort of patients to be able to research further. I think validation is something that you talked about. So again, we are doing a lot of work around sort of generating computable phenotypes, looking at different subphenotypes. So the hypothesis generating and some of that work that we're doing can be validated with some of these prospective data. That's just a few. Vitaly, I'm sure you can think of others as well.
Yeah, thanks, Suchitra. I completely agree with your excellent answer. Yeah, certainly the EHR cohorts give us a great platform for emulation for testing hypotheses before they turn into trials for the prospective cohorts. One thing also worth mentioning is that we have large sample sizes, so we might be powered to see, find statistically significant effects that might not be detectable in the prospective cohorts. And then kind of vice versa, as Suchitra alluded to, in our computable phenotyping work, these questions of attribution, of how to define exacerbation, those might be the survey data from the prospective cohorts linked to EHR data could be a great place to look into some of those questions that are hard to answer from the discrete EHR data alone.
Great. I will hold the rest of my questions for now, although I have some ready to go, because there's so many great things to ask, but we want to give an opportunity for the questions in the chat to be answered.
All right. Well, thank you, Dr. Tantisira. Yeah, if we've got a few minutes at the end there to circle back, we'll see if we can squeeze those in. We do have a lot of questions that have been coming in. Some of them have already been answered by our panelists. So Dr. Rao dropped one into the chat there. That's moved over under the answered questions, so you can check and see if your question has already been answered, but please continue to bring those in there. So the first question I have kind of continues this. What we were just touching on about the value of the EHR cohorts and testing hypotheses. So this is a question to both our panelists about whether you've been able to look into the effects of possible interventions, such as patients that may have been prescribed pharmaceutical interventions. We could name them, but those that are out there as possible interventions for long COVID. Is that something that has been talked about? Is that you're aware of, that it's on the list of future things to do? Or if you guys could speak to interventions and cohort data. Mm-hmm.
Yeah, so we're in the process of working on a study looking at specifically remdesivir and dexamethasone, their effect, as COVID treatments on risk of developing long COVID. We've looked at Paxlovid a little bit in a query in the past, and I think there have been other treatments also discussed. So there's definitely work in progress on a few different treatments. I think also we did in the study that Suchitra presented on, we did also take a look, this is in the supplementary appendix, at kind of broadly which drugs tend to be prescribed to COVID positive patients as compared to COVID negative patients who don't have COVID. So not effectiveness so much, but just looking at kind of in practice, which drugs tend to be prescribed.
Dr. Rao, anything to add to that?
Yeah, I was just going to say, so then based on that work that we did sort of that was sort of an adjunct to the work that I just presented. Some of those medications were really used to try and treat some of those PASC symptoms. And so it was more just those supportive care measures. So if folks had ongoing cough, it was looking at cough suppressant medications or non-steroidals and things that might be helping, again, sort of more of those acute symptoms. So again, we just saw that there was some association, but there wasn't sort of enough power to really be able to show that that then led to improved recovery or faster recovery. So that those weren't really designed to look at true comparative effectiveness. So the only other thing I was going to mention is really the work that we've done in the first year of this Recover initiative is to look at sort of detecting PASC and sort of defining PASC. And then the next steps for us are really going to be looking at treatments of PASC. So speaking of the work that Vitaly is talking about, that's definitely going to be a very heavy focus for us in the next year, as well as looking at sort of preventative aspects as well. So are there other things that we can do to try and prevent those symptoms from occurring in the first place, or at least reducing those symptoms duration?
Great. So the next question we have actually is coming. It's been asked a couple times by our audience members, and this gets into some of the rule set and the inclusion and the identification of patients within the data set. How is all of this impacted by those that may not have had access to testing early on? So in spring of 2020, their being able to get to tests was difficult, or later on where they may not have tested because symptoms might have been more mild and then complications developing further. So I wonder if you guys could speak to the absence of testing and how that plays in.
Yeah, I mean, the folks that pose these questions absolutely hit the nail on the head, that we're really sort of at the mercy of the data that we have that come into our EHR. And we acknowledge that that is going to be one of the limitations of looking at things like the incidence of PASC at the beginning phases of the pandemic. So we know that testing at that time was very much restricted to sicker patients, those who might be more likely to be hospitalized, had access to those test centers that were sort of built around those larger, facilities. So we definitely acknowledge that and have seen a little bit of a signal for things that may not really be the case. And so that's what we have to take into account. And then testing became sort of more widespread and more reliable. And then we went into the issue of at-home testing. So now people aren't going into those centers to get the tests. They're doing all of their testing at home. So the period of time that I looked at with our study was March of 2020 through to October of 2021. So we're less at the mercy of the at-home testing phenomenon, but we certainly are at risk of bias when we are looking at that early period. And so when we design studies, we have to think about these things. It's still better to try and explore these questions using what we have, but there may be some caveats. We might not be able to give those precise incidence estimates at the start of the pandemic, for example, for those very reasons. And then we have to think about a combination of approaches. So it made sense to really look at testing during that first period of time when it was more reliable. But then when you get into latter phases of it, and we couldn't use the U09.9 code because it didn't exist until October of 2021. So then you have to sort of evolve the way you design your studies. And so maybe we use more reliance on other codes and less, or you have to sort of acknowledge that there may be limitations with looking at SARS-CoV-2 PCR testing alone. So that's where over time we've had to sort of take into account these factors, look at a combination of different approaches. And this is why it's good to do work in different ways, because we can sort of then look at similarities, look at differences, look at if something works, then sort of pursue that technique further. So that's a really important and great question.
Yeah, totally agree with everything that Suchitra said. One specific issue that we've discussed a lot has been that patients who are diagnosed with long COVID with that U09.9 code, more than half of them don't have a prior viral positive test result recorded in the EHR. So it may be one that was conducted at home or outside of the network, which feeds into the EHR data. And so that makes it challenging, for example, to figure out the time at which patients had COVID, which is important for some studies. There are some things in the case control comparison studies that we've done to try to mitigate this somewhat. For example, oftentimes our control groups have been patients with a negative SARS-CoV-2 test and using that to determine the index date. So at least there's some more confidence that the patients didn't have COVID at the time of the index date, even if we didn't didn't capture the positive COVID test results at other times. There's also been some studies where we've looked at non-contemporaneous control cohorts, such as patients with respiratory illness in 2019, so that the presence of COVID, patients with COVID in our control cohort, where that's not a concern, although that comes with its own difficulties concerning differences in utilization prior to the pandemic as opposed to during the pandemic.
Kind of the related question to this one is, with the ICD codes that are used, thinking more broadly, are these codes, what about international data? Are there other countries that have long COVID codes, or is this an approach that could also be replicated in other EHR data sets across the world?
Yeah, that's a great question. So we do know that there are some countries that do have diagnostic codes for long COVID and long COVID conditions. I don't have a list of all of the different countries at easy access, but that does afford some opportunity for us to take a similar approach and explore that in sort of another setting. But it's very across the board. They're sort of instituted at different times. And then these are just a good way to highlight some of the challenges of trying to do sort of cross-country collaborations, because again, there might be sort of different utility of when those codes are being used in those settings compared with our settings, et cetera.
Yeah, unfortunately, I don't know too much about coding practices in other countries. I think that's a great question. But I think, outside of my expertise.
All right. Well, thank you. So our next question is, we'll start with Dr. Rao and then come back over to you, Vitaly. So in the analysis that the team's looking at, how do individual symptoms like tinnitus or sleep disruptions, how do they factor into the study? Recognizing that there is a wide range of symptoms. What about those symptoms that might be less common or those that we didn't see on the slides listed today?
Yeah, thanks for that question. So absolutely. So there is such a wide spectrum of manifestations of PASC. And you saw in those earlier slides that we, based on even just sort of review of the literature, clinical adjudication, sort of sharing our sort of experience in terms of sort of taking care of these patients, we had 441 sort of clusters of potential diagnoses of symptoms or conditions associated with PASC. So we, didn't report out all of them. We really just focused on the ones with the strongest association. But yeah, absolutely, there's going to be other conditions and other findings that have been reported and new ones that might be continuing to be reported. So those do sort of factor in when we're trying to look into sort of incidence rates of PASC. Those become really important when we're trying to sort of characterize the full spectrum of PASC. And those may then be relevant too when we're doing sort of prospective studies. We make sure that we're asking questions about things like tinnitus, about things like, different, memory problems or skin rashes. And so I think these then sort of get factored into sort of other studies down the road. The study that we were doing was really trying to look at those stronger associations. But we acknowledge that there's that whole spectrum of things that may not necessarily be flagging in the highest sort of risk category.
Yeah, I think just to add to that, I think this is one place where the tree-based scan statistic, like that approach, might provide some additional signals. So for example, I did look to see whether there were ear infection related codes that were occurred disproportionately among the cases in our comparison. And when we compared patients with COVID to patients without COVID, so that like sensitivity analysis I described, there we did see some signal for some ear infection related codes. So so I think that's that's the value of doing kind of multiple comparisons and trying to synthesize them. And yeah, I think, there's like in our manuscript, there's a table that kind of lists clusters of codes, specific codes that all seem to be associated with PASC diagnoses or with COVID positivity in the post-acute period. And so, going through these in more detail, having like studies specific to those conditions down the road, we think would be really important.
Great, thank you. And for those of you who are on the line, for all the mentions about the publications, we have a publications page on recovercovid.org where these prints will be available and linked to, so you can check those out. And then also you can, in the survey questions, if there's any questions or ideas or topics you'd like to see in the future, you can jot those down there as well. We've got time for one or two more questions. This is going to be an easier one here, or at least I think so. How do all of the different variants of COVID-19 play into this analysis? Like we've heard Omicron mentioned, and then we also have early on with the severity of the different variants, and how does that tie into some of the analyses that you guys are looking at?
Yeah, another really great question. So when we think about the whole sort of course of the COVID-19 pandemic, we do need to be thinking about these in terms of different waves. But we have to be careful not to assume that the patterns that we're seeing are related to a variant and their sort of inherent virological properties. It could be other factors too. So it could be that over time, we end up with a population that gets immunity through exposure from infections and from vaccination. With EHR data, there's also changes in people's practices in terms of how they code data, in terms of new codes that develop. We talked about, UO 9.9. And so when we conduct these studies and do these, we have to think about not only the inherent properties of the virus, the changes of immunity over time, the ways that the healthcare system has been managing these with new therapeutics, et cetera, but also how patterns of healthcare seeking and healthcare reporting change over time too. And so with the study that we looked at, again, we were sort of looking at the early phase before the Omicron period hit. And then Vitaly's study looked at periods of time beyond that. And so we do a lot of work where we try to break things down into phases too and see, okay, during different time periods, are we seeing differences? But we have to acknowledge that it may not just be because of that variant, that we're seeing these signals. Some other work that you've heard Vitaly talk about is sort of temporal trends. So looking at different presentations of PASC and how they change over time. We've been doing that over variant period. We did something similar with MISC. So we wanted to see what was happening with the severity of MISC over different time periods. We found that the severity was actually going down, but that's not to say that Omicron is less virulent necessarily. It's just there may be more population immunity. So just to kind of summarize my response, it is something that we are looking at with a lot of the research that we're doing here, but we're trying to be mindful of what some of those changes and variations across the time periods truly represent.
Yeah, I second everything Suchitra said. Just to give one more example, in our study, in our preprint on kids with diabetes and their trajectories over time, we did look a little bit at pre-Omicron and Omicron effects, and we saw potentially some differences there. But yeah, so Suchitra said, yeah, it's not just the variant; it's like a very big. There's potentially a lot of confounding from just utilization patterns, like in summer 2021 when patients started coming in for other things more. That can throw a wrench into a lot of analyses and require more careful planning for sure, as well as other respiratory illnesses, flu, RSV becoming diagnosed more frequently. Potential for confusing that. Symptoms of that with COVID, all of those things become more difficult later in the pandemic.
All right, and we're going to close with one last question, and really this is circling back to one of the earlier questions about the comorbidities and risk to children and adolescents with pre-existing conditions. And I wonder if you both could speak to what you're seeing within these populations, and whether there's disease types or other confounding factors that may be increasing the risk of seeing PASC in these children.
Yeah, so maybe I'll start just with, we did a study that just took a broad look, the one I mentioned before, comparing patients with existing chronic conditions who had COVID to those with chronic conditions who didn't. And what we saw there is that I think we saw, I don't remember off the top of my head, but something like, patients with chronic conditions were somewhere around like twice as likely to be hospitalized following COVID infection compared to patients who had chronic conditions who did not have COVID. However, when we looked into specific kinds of chronic conditions, we kind of saw like effects across a lot of different clusters. And, it wasn't so clear to us, and it's hard to disentangle how often this is, there's like a causal effect between, there's some biological mechanism between COVID infection and something that exacerbates the chronic condition versus, just increased surveillance, like patients who have a chronic condition and then have COVID being more likely to, see the doctor, be admitted to the hospital just by virtue of like having the chronic condition and COVID at the same time, but not necessarily, there being a causal relationship. So those things are very hard to disentangle. And, in our work on long COVID subtypes, we're definitely, seeing some differences between COVID subtypes based on, patients who have presence of existing chronic conditions. There seem to be kind of subtypes involving patients who, have a high volume of utilization, have like chronic conditions affecting multiple body systems, have a lot of laboratory testing. And the extent to which, these are, to the extent to which, it's the existence of the chronic condition that's kind of driving this versus something about how PASC interacts with this is definitely a challenging question that we're trying to look into and to differentiate these further.
All right, thank you, Dr. Lorman. All right, and with that, please join me in thanking our panel of investigators and our discussant for taking the time to share these updates with us and our audience for joining us today. The FAQ for this webinar is going to be posted along with the recording on recovercovid.org. The FAQ is going to include those answers to the questions that are relevant to today's webinar, as well as those that were submitted in advance or during the session. Questions about other scientific topics will be addressed in future webinars, and answers to broader questions about Recover will be available in the general FAQ section on recovercovid.org. As we close, we invite you to come back and attend future R3 webinars as we dive deeper into some of these broad topics that were discussed today. If you haven't already, remember to sign up on the website to receive future announcements and details about our upcoming webinars. And lastly, if there's topics that you'd like to learn more about, please be sure to enter those ideas into the survey that's going to be popping up onto the screen, and write those in there so that we can make sure that we're sharing the results back that are of relevance to you. Thank you again to our presenters and our audience for joining us. And this concludes today's R3 webinar. Thank you.